to Q&As. So we'll just like to check if Michelle from Alaska, she is online with us, so she could eventually take some of the questions. I don't see. Michelle, can you hear us? Well, eventually, while we try to solve some technical problems, I would start maybe to start collecting some questions from the audience. Okay, that's better. Okay. Does anyone have like some questions for either the first one or the second presenter? Eventually. Nothing yet? Hmm? Can
I ask a question of the audience?
Yes, you can.
Does anyone else have similar issues, or have they experienced
similar issues in trying to get change to happen across organisations? There's nods.
I think everyone has issues, but like...
And what have you done?
Can we have a mic? Here in the...
If you don't ask me, you see, I'll ask you.
He's arriving. So, I will actually ask you to introduce yourself, so...
Oh, right.
Okay.
Is that on?
It does work, yeah.
Yeah.
Yes.
I'm June Roberts from Salford in the northwest of England, and we've created an integrated care organisation where we have adult social care, acute and community services, mental health, and we're working in an alliance with our general practitioners and with our voluntary sector. And we've been particularly trying to tackle frailty, and the leadership style has to be very inclusive, have to listen very carefully and understand each other's issues. And as you said, it's a long journey. It's not something that's going to happen overnight, and you really have to work at it to keep your partnerships going and to keep your staff engagement really strong. So although we've set a direction of travel around the integrated care agenda, what we really try to do is also get the ground up ideas, because things that you've just discussed around frailty here have come from the ground up. This is what we need to do differently. And with Michelle, using a real quality improvement methodology. So we're not setting off and putting pilot schemes in, we're doing tests of change and using the same PDSA cycles so that you can really see if something's working and change direction. If not, and that's engaged the staff particularly well, I think.
Thank you.
Do we have any other questions from the audience? Looks like we don't. So actually, I wanted to ask you something from my side. You know, from your presentation, you know, you set out some, let's say, challenges or things to consider at the end. What's the first one that you would actually, you know, put there as sort of priority? You know, something also coming from the first presentation was the importance of evaluation, how this takes time. So what's like, let's say, if you have to pick one thing to let's say to start it, to kick off the process?
Well, the next step, I guess, is I think a lot of this work is, as we say, you don't ask for permission, you just ask for forgiveness. As long as you've got the clinicians behind you and it's in best for the patients, we choose the bits that's going to have, I guess, the best impact with what we've got. And I made note there of the need for us, where we're at, looking at that group of patients or people who are in the community who are at risk. And really we want to look at addressing that so that those people aren't actually coming to ED. I think, you know, all those other things aside, with the sort of professional stuff. I think that the way that you overcome that is having the evidence and having the data to say at the end of the day, it's making a difference to people's lives. And it really, and that's what we've done with, you know, that's what we do. We do research. It does take a while for it to get published and out into the public domain, which is a problem. But really to carry on doing that, creating the evidence and including, in our case, carers rather than the patients themselves, for all the reasons I've said. And just, you know, to show that it works. And I think there is a lot of interest in what we've done and other people are starting to do it. So it's really not to stop and wait and let the barriers take you down, but look at those people who are willing to go with you and take that and create the evidence to do it. Because otherwise, I think there's that, you just get stagnant and it, you know, they can stop you if you don't just let it keep going. But that's just me.
That's great. I see some technical communication. Okay. Only audio. Okay. So I think we now solved the technical issue with the connection. Oh, sorry. We have another question in the meantime. Sorry.
Yes, I have a question.
Okay, good.
But excuse, I am French and don't speak English so well.
Better than my French.
And you had something on the last picture about incentives. And I would like to know what kind of incentives you had.
So, is that the one? Oh, you haven't got it there, it's up there. So, rather than incentives as in money, because we can't change that, really we try to make the incentives about it's engaging the patients or the carers and trying to look at how we collect the data. We know that we've collected data to say, in our case, in just one site, but what the cost and how it's more efficient to do that. But in doing that, you know, you can say it's a 10-to-1 cost benefit, but the problem with that is that it's saving us money, but the cost is going somewhere else. So what we're trying to do now is to say, well, it's you know, a 10-to-1 cost benefit for this organisation, but where else does that cost then get passed on to? So, you know, we're trying to make the KPIs around, it's not about people who are being admitted, it's about more the social determinants. You know, is that where they're going home, is that where they choose to be, rather than medical people thinking they need to be in a hospital, if that's their choice to go home. And the incentives in this case would be those based on what the patient wants, not necessarily on what the funders want. So it's trying to look at it from a different way of addressing it, because we can't change the funding structure. We're trying by creating the evidence, but we can't just go and change that. Australia doesn't have that sort of blended or capitated model that we can do that yet, but we're trying to create the evidence to do that. And the way we do that is through really the patient outcomes.
Okay, so we connect with actually our speaker. We have about 5 minutes left, so
Over here.
There's one question there, and then, but we also connect from, sorry?
Alaska.
The last question, yeah, the last question, okay.
Hi, thanks very much for the presentation. It was really interesting. My name is PJ Hart and I'm from the Integrated Care Programme for Older Persons in Ireland. So we have a number of examples of what we call FIT teams, which is a frailty intervention therapy team within the emergency departments within the 13 sites that we have. And the emergency department intervention is very attractive for a number of reasons. The early results are very good. You introduce a service that wasn't previously there. You turn around a lot of people who might otherwise be admitted. But a couple of things that have proven to be problematic, which we're trying to get to grips with, and I'm wondering whether you have had the same experience. So without an end-to-end pathway agreed, without the community services agreeing that if people are turned around, they'll put in an immediate intervention in the home the following day or that evening, then the risk is that some of those emergency department teams can be quite disconnected and be splendid examples of good practice, but in isolation from the rest of the end-to-end pathway. So for us, it's been really critical to ensure that it isn't just one component of the pathway that performs well, but that the rest of the pathway is in place and that there's agreement in terms of a high turnaround and quick response, so that the results that appear to be very attractive to policymakers or to funders are understood in terms of the totality of the actual pathway.
Yeah.
I wonder whether you've had the same experience.
So that the statistic there that said there was a 220% to our Mater at Home, that Mater at Home is a multidisciplinary, it's got doctors, nurses, allied health, it's got the whole lot in there. And they see anyone who in the community, but from our health service. They've been there since I've been at the Mater, they've been there for like 20 odd years. And they've never been used by the emergency department. Never. Like, I'd count on this hand how many referrals they'd get, probably in 6 months. But since having had the team in there, the older person team, whose focus is that continuum of care and what the person needs and where they need it, you know, that's why it's gone up 220%. And the 70% of that increase has been from our team. The rest of it is from the rest of ED, because it's kind of more by osmosis that they're saying, well, they're referring these group of people to there. So I think the fundamental shift is because these particular group aren't ED nurses, and they look at it, as you know, in a very different way than if someone's coming in with a trauma or a broken leg or the child that swallowed something. It's not full on. It's more about that, collecting all the information, talking to the general practice, talking to the facility, and then about what their ongoing care is, not just we'll fix them and off you go. So I think it's collecting that information. If we just said they come into ED and we get them out again, that's great. But the fact that not just have we impacted on the increase of care in the community, but the impact that then has for the rest of that department, because the EDs have never referred to community providers. They just fix them and they either go in or they go out. So I think it is really important, and we work really closely with that team to show this isn't just about this one group of people, it's about what else is out there that then leads to. So I think you're very right. You have to look at it from the whole population perspective. And what we're going to, we want to look at sort of who they're actually referring in that group, because ours are all older and frail. Having said that, we've had an 18-year-old, because frailty isn't actually limited to age. So we call it the older frail person thing, but if someone comes in and they're frail, we still see them, or the team do. But yeah, to look at what the knock-on effect of that is, because I think that's a fundamental problem within the system about how we treat people. Hospitals in particular, do tend to silo people. So, and if we keep doing that, we're going to end up at the same place. So we're quite encouraged by the fact that we've got such it's like, this effect that's been affected everywhere else, but we now need to look at how we take that further. But you're very right. That wider impact is really important.
Okay, so I think we have finished our time. So thanks again, everyone, for being here. Thanks for the translator. Thanks a lot to the speakers and for the video intervention from Alaska. You can always connect after the session, and have a nice day. Thank you.